So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN Neuropsychiatry, in collaboration with Roche, is organizing an educational activity entitled Breakthrough in Multiple Sclerosis, Neuromyelitis Optica Spectrum Disorders, and MOG-associated disease. During this webinar, our top-notch neurology experts will discuss the new monoclonal antibodies approved for the treatment of NMOSD and multiple sclerosis. In fact, until recently, disease-modifying agents specific to NMOSD were not available, and patients were treated with various immunosuppressive drugs and regimen with variable success. Fortunately, since 2019, 3 new therapeutic monoclonal antibodies were approved for the treatment of this disabling disease. Similarly, for MS, there has been recently a dramatic evolution in the arsenal of MS treatment. And among the developed therapies were anti-CD20 monoclonal antibodies mediating B-cell depletion. Although selective B-cell depleting therapies has demonstrated strong efficacy and good safety profile in MS, one of the major current controversy involved the optimal timing of their use during the management of the disease. Tonight, Professor Yammout and Dr. Muna Thakur will debate the early versus delayed initiation of B-cell depleting therapies in MS. Before introducing our first speaker, let me thank Roche for sponsoring this educational activity. In our first session, Professor Yammout will explain to us how to differentiate between multiple sclerosis, neuromyelitis optica spectrum disorders, and MOG-associated disease in terms of diagnosis. Professor Bassem Yammout is currently the director of the Neurology Institute and MS Center at Harley Street Medical Center, Abu Dhabi. He is also a professor of neurology at the American University of Beirut Medical Center. He received his training in neurology at the University of Cincinnati, Ohio, followed by a fellowship at the Montreal Neurologic Institute at McGill University. Professor Yammout is also the head of the clinical research at the AUB MS Center, president of Menactrums, and fellow of the American Academy of Neurology, and member of the MSIF International Scientific Advisory Board and multiple regional and international multiple sclerosis advisory boards. Professor Yammout is one of the leading experts on MS in the Middle East, with recent research on epidemiology, quality of life of patients in the Middle East, treatment, novel therapies such as stem cell and venous stenosis, and the impact of war on MS. In addition, he is currently the principal investigator on several ongoing international MS trials. Professor Yammout has authored many research and review papers and is currently the chief editor of the MS newsletter MS Today and on the editorial board of the Multiple Sclerosis and Related Disorder and Pediatric Neurology Journal. Professor Yammout, it's our honor to always have you with us as a speaker. Welcome, and the floor is yours.
Thank you very much, Maya. And thank you for Roche for inviting me to give this presentation. You can see my slides.
Yes.
So the aim of this presentation really is to differentiate the 3 main central nervous system demyelinating disorders that we see in our clinic every day. MS, neuromyelitis optica spectrum disorder, and MOG-associated disorder. How do we differentiate them clinically and radiologically? These are my disclosures. So also NMO or Devick's disease has been described by Devick at the end of the 19th century. Also the 20th century, there was a debate whether it was actually part of the MS spectrum or a separate disease. Finally, by the 1990s, it was decided that this is really a separate disease, and they called it Neuromyelitis optica, and has specific MRI and CSF features that differentiate it from MS. The major breakthrough in differentiating those two diseases came in 2004, when the group in Mayo Clinic discovered the aquaporin 4 antibody. And this IgG antibody was highly specific to NMO. To the point is that we think it's really a pathogenic antibody, so the antibody causing the disorder. From there on, the diagnostic criteria for NMO based on this new antibody evolved, and finally, we got our unified diagnostic criteria by the Mayo Clinic in 2015, which I will discuss. So NMO prevalence is very low. So unlike MS, where we see a prevalence between 60 and 120 per 100,000 in our MENA region, at least, and up to 200 to 300,000 in Northern America and Scandinavia, the prevalence of NMO ranges from less than 1 to 13 per 100,000. So it's way much less prevalent than MS. But the interesting thing is that this prevalence is the same everywhere, in the Middle East, in Japan, in North America. It doesn't change with the different populations and the different latitude, just like MS. It's much more predominant in female. Almost 90% of the patients are female, so more predominant female than MS. They present a little bit later than MS, so they present, the mean age is around probably 40, while the mean age for MS onset is around 30. So it's not unusual to diagnose NMO in patients that are above 50, while it's very unusual in MS. As a rule, NMO is always a relapsing disease, unlike MS, which can be progressive from the beginning or secondary progressive after a period of relapses. NMO is always relapsing remitting, but the relapses are very disabling. The aquaporin 4 antibody, IgG antibody, is really present in the astrocytic food processes that are around the endothelial cells. And this localization of this antibody really has a major role in delineating where the MRI lesions in NMOSD will be, as I will show you now. So the criteria, as I mentioned, the diagnostic criteria developed by the Mayo Clinic and their allied teams from all over the world, basically stratified the NMOSD spectrum disorder, which we call NMO spectrum disorder, or NMOSD, which is a new term we're using now instead of NMO, into two categories. The NMO cases that are positive for aquaporin 4 IgG antibody, and the NMO cases that are negative for this antibody. They discovered at one point in time that there are many cases of NMO that are typical of NMO clinically and radiologically, but had a negative antibody. So this is why these criteria were finally designed. So the two parts, the two subgroups for diagnosis, number one are the ones that are aquaporin 4 antibody positive. As I mentioned, aquaporin 4 antibody is highly specific for NMO, so you rarely see it positive for anything else. So as soon as you have a positive aquaporin 4 antibody with any demyelinating syndrome, then it is NMOSD. So it's as simple as that. So the requirement once the antibody is positive is only one core clinical characteristic. What are the 6 core clinical syndromes that NMO present with? Optic neuritis, myelitis, the area postrema syndrome, which is the myelination in the dorsum of the medulla leading to severe vomiting and hiccups, other brainstem syndromes, which can be imbalanced and so on, the diencephalic syndrome that can present with sleep disorder, it's rare, and finally, symptomatic cerebral syndrome that can present with weakness, sensory loss, and so on, like MS. So the 3 most common core clinical characteristic or presenting syndrome are the first 3, the optic neuritis, the myelitis, and the area postrema syndrome. But any demyelinating disorder fitting any of those 6, which can be any syndrome basically, with a positive antibody is NMOSD. Now the problem starts, these are the prevalence of these syndromes. As you can see, myelitis and optic neuritis are the most common. 32% will have any optic neuritis, almost 40% will have a myelitis. Area postrema comes second as 10%, and the other three syndromes are quite rare, occurring in between 3 and 5%. So these are the three main clinical core syndromes that you're most commonly going to see in those patients. Now, as I said, the problem comes in those around 25 to 30% of NMOSD cases that are antibody negative. And in that case, you have to be more stringent with your diagnostic criteria. It's not enough anymore to have any demyelinating syndrome. Now you have to have very specific clinical and radiological syndromes to make the diagnosis. So the diagnostic criteria in aquaporin 4 antibody negative cases is at least 2 core clinical characteristics, not 1. And one of those 2 has to be one of the typical 3, optic neuritis, myelitis, or area postrema. So 2 core, one of the 3 is one of them. There should be dissemination in space. So you cannot have the same syndrome recurrent. So recurrent optic neuritis alone, recurrent transverse myelitis alone do not qualify as 2 core clinical characteristics. And once you have one of those core clinical characteristics, they should be accompanied by specific MRI finding. So your myelitis should be accompanied on MRI by longitudinal extensive transverse myelitis, which is a long demyelinating lesion extending at least 3 vertebral levels. So not any myelitis will fit the criteria. If you have an optic neuritis, it should be accompanied by a normal brain MRI, completely normal, or at least half of the optic nerve, so a longitudinally extensive optic neuritis, if you want to call it, which is more than the half of the optic nerve is involved in demyelination, or involvement of the chiasm. In case you have the area postrema syndrome with the vomiting, the severe hiccup, there should be a demyelinating lesion in the dorsal medullary area. So now we have to have 2 core clinical characteristics, and each one of them have to have the specific accompanying MRI features. So this is an example of this MRI feature. For the optic neuritis, we can see here the normal optic nerve here. And on the left, we have an extensive demyelinating lesion extending through the whole of the optic nerve. So more than half of the optic nerve involved. In this case, this is the chiasmatic involvement. We have the chiasm with bilateral involvement of the chiasm. In this case, of an optic neuritis. Transverse myelitis, you have your typical longitudinally extensive transverse myelitis extending over many, many vertebral level. We can see it here. We can also see it here. Now, they added to the criteria that if there is a history of transverse myelitis, which is not acute now, then instead of looking at a demyelinating lesion, you can look at atrophy. And focal spinal cord atrophy, like here, extending more than 3 vertebral lesions can be one of the diagnostic MRI criteria for myelitis in NMO. And we can see here the normal spinal cord volume, and then severe atrophy, which is focal over at least 4 or 5 segments. Another feature before I go to the next slide is that if you look at the transverse spinal MRI, the MRI lesion in NMO are always central, and you can see here they are central. They involve both the central gray matter and the white matter around it, and you can see it here, as opposed to the MS lesion, which are usually not central, they are smaller, and they are peripheral, most commonly in the posterior column or in the lateral column. And we can see here an MS lesion in the posterior column, another one in the anterolateral column. These are typical MS lesions, as opposed to the centrally large located lesion in NMO. This is the area postrema lesion, which we can see it in the dorsum of the medulla at the base of the 4th ventricle, and we can see it here and there, and it can be enhancing. And this finding should be accompanying the core clinical characteristic of severe vomiting and hiccups to fulfill the diagnostic criteria. In case of a brainstem syndrome, you should see this periependymal, which is always periventricular continuous demyelination, which we can see here, or around the aqueduct of Sylvius, or surrounding the 4th ventricle. And this has to do really with the localization of the aqua4 antigen, which is present usually in the subependymal area, so around the ependyma, around the ventricle. And this is why we see what we call this pencil head demyelination surrounding the whole ependyma around the ventricle, aqueduct, and so on. So this is one of the typical radiological features you should have with your brainstem disorder. With the diencephalic syndrome, you should see this thalamic lesion bilaterally. This, of course, is a very rare syndrome. And with the cerebral syndrome, which also is a rare representation of NMO, you should see extensive subcortical demyelinating lesion, which you rarely see in MS, except maybe for tumefactive MS. Other features that are typical of NMO, as I said, is the periependymal. This is another picture of the periependymal involvement, and we can see that the whole ventricle is surrounded by demyelinating lesion, which is almost continuous. We can see it here as a pencil head. We also see in these lesions what we call the lesion which is following the corticospinal tract, and we can see here on the coronal a lesion exactly following the corticospinal tract from the centrum semiovalis all the way to the pons and midbrain. This is also typical of NMO. And finally, we have what we call this cloud-like enhancement, which you don't see in MS. In MS, you see enhancement local, like these lesions. But this cloud-like, which is diffuse enhancement, is typical of NMO, and again, would be one of the criteria that could be suggestive of NMO. Now, the central vein sign is a very interesting finding. It has been recently described in studies, and we can see it here when you superimpose a FLAIR study on an SWI study. The SWI will show the vein, the FLAIR will show the demyelinating plaque, and superimposing both will show you that every plaque has a central vein within it, because the pathophysiology of demyelination MS is that there is a perivenular inflammatory infiltrate that will spread around the vein, causing progressively centrifugal demyelination away. So you end up with a central vein and a core of demyelination all around. Central vein sign is not usually seen in NMO. And in this interesting study where they look at the percent of lesion with central vein sign, and we can see if you look at a 50% cutoff, then all of your MS cases are here, and almost all of your NMO cases are down except few. So at a 50% cutoff, if 50% or more of your lesion that you're seeing have a central vein sign, it is MS. If less than 50% of these lesions have a central vein sign, it's suggestive of NMOSD. And this accuracy is high with a sensitivity of 93%, specificity of 88. So it's almost a 90% accuracy just by the central vein sign to differentiating NMO from MS. Finally, two features that are typical of MS that you don't see in NMOSD, and these are number one, the Dawson finger, which are the lesions perpendicular to the ventricles, which are also these lesions that are forming around the vein because the vein goes down from the surface of the brain perpendicular to the ventricle down. And the second one are what we call this inferior temporal lesion. And I'm showing one here adjacent to the temporal horn and enhancing. Of course, it can be non-enhancing. These two features, the inferior temporal lesions, adjacent temporal horn, and the Dawson fingers are usually typical of MS. And if they are present, you should probably rule out the diagnosis of NMOSD. In spite of all of that, we still misdiagnose NMO. And actually, when they looked at the proportion of patients diagnosed with MS prior to making the right diagnosis of NMSD, it reaches almost 42%. So 42% of NMOSD cases were initially diagnosed as MS. So we have to be very, very careful and be very stringent with all these criteria, always be vigilant to all these MRI features, these clinical features, to make sure we make the right diagnosis, because the treatment is really completely different. And actually, if you treat NMO with medications for MS, you might worsen the disease. And in our own differential diagnosis study that we did between Lebanon and Kuwait, NMO was the second most common wrong diagnosis in MS patient after the non-specific MRI and psychogenic symptoms, accounting for almost 10% of patients with MS that were misdiagnosed. Now, how differentiate in In brief, between NMOSD and MS, as I mentioned, the prevalence is similar and low everywhere, while MS is prominent in certain areas of the globe. NMOSD mean age of onset is 40, while it's 30 in MS. And I also mentioned that it's most commonly involving the optic nerve and transverse myelitis much more than the cerebral and brainstem syndrome, while in MS, any area can be involved as commonly. Remember, in NMOSD, we don't have the typical MS lesion, which are the Dawson fingers and the periventricular inferior temporal lesion. We have the LETM, the longitudinal extensive transverse myelitis with NMO. The CSF, we commonly have high white count. Any white count above 50 white cell is a red flag for diagnosis of MS. Oligoclonal band are not usually positive, only 10 to 25%, as opposed to 95% in MS. The aquaporin 4 antibody is highly sensitive, but is highly specific, but is not as sensitive, occurring only in 75% of the cases. The attacks are very severe and usually disabling. The main clinical pitfalls with these diagnoses, if you are suspecting NMO, but there are actually brain lesions, and then you're confused, could this be MS? So look at the central vein sign. Look at the periependymel, as I mentioned, the pencil head localization of the lesions. Look at the cloud enhancement. These will help you show that these brain lesions are atypical for MS. And of course, the absence of the periventricular or inferior temporal lesion or Dawson finger, as I mentioned already. If you're suspecting MS, but the brain MRI is normal, remember that number one, early in MS, sometimes you can have a negative brain MRI, but usually you have a positive spinal MRI and positive oligoclonal band. And remember that it could be primary progressive MS. So initially in the progressive course of MS, you might have many spinal lesions, but no brain MRI lesion. And again, the course will differentiate an MS from NMO because we don't have progressive NMO. And if you're suspecting NMO, but the oligoclonal band are present, of course, this can still occur in NMO, since 20% of NMO cases might have oligoclonal band. But if you would suspect MS, but if you're suspecting MS, but there is an LETM, remember again that LTEM is occasionally seen in pediatric MS and in late MS. So the LETM, the longitudinal extensive transverse myelitis diagnostic import is early in the disease, not late, because late on, with recurrent demyelination, the lesion in the cord will coalesce in MS and show as if they are in LETM. Like this patient with MS, but very late after 15 years of MS, and it looks like LTM, but actually initially it was multiple lesion, and ultimately with more lesion accumulating, it looks like now the whole myelitis is continuous. Aquaporin 4 is highly specific. If you look at these tests, you can see here the NMO cases and the control. Not a single control has a positive antibody with anything used, the cell-based assay, which are highly sensitive, or the ELISA cell. So it's highly specific once it's positive. However, the sensitivity of the cell-based assay is much higher, reaching around 70%, as opposed to the sensitivity of the ELISA. And you can see here many NMOSD that are actually antibody negative, while the number is much lower. So with ELISA, probably you might have a 50% sensitivity. Always order the cell-based assay to increase your sensitivity to around 70%. Now, let's go to MOG antibody disease. And MOG is basically an antigen that is present on myelin. And this is a very specific antigen of the myelin outer lamella. It has been recently found that basically some patients that have the myelination and are suggestive of NMO, but are NMO antibody negative, are positive for this antibody MOG. However, it was found that this MOG antibody positive has special characteristic. Number one, there is no female predominance. They are equally distributed between male and female. 50% of the MOGAD case, MOG-associated disease, are monophasic, so just one attack and then no more recurrence. They always have a better outcome than NMO. And the onset is usually typically either optic neuritis or transverse myelitis, much more than any other cerebral or brainstem syndrome. In 2018, they put down the diagnostic criteria for MOGAD, which is basically acute optic neuritis, myelitis, brainstem encephalitis, or any encephalitis. MRI or electrophysiological evidence of CNS demyelation, and a positive MOG antibody by cell-based assay. So if you have this typical demyelinating syndrome with a positive MOG antibody, the diagnosis can be made. However, if you look at our MS patient, around 4% will have a positive MOG, even if though they are compatible with MS and typical of MS. So a more recent study, this was done in JAMA last year, published, showed that what's important in MOG, unlike the aquaporin 4 antibody that is very specific, once it's positive, it is NMO, in MOG, the titer is important. And if the titer is below 100%, then the specificity of the antibody becomes less. And if it's between 140 and 120, you commonly see it in MS at low titers. So to be sure that this is MOGA, the best way to look at it is to look at an antibody that is above 1 in 100. And if you look here at the sensitivity, once the MOGAD is around 1 in 1,000, the sensitivity is 100%. So every single case is a MOGAD case. At 1 in 100, it's 82%. But once you're down in 120 to 140, the sensitivity is very low. 50% of the positive case will not be MOGAD. Most likely they will be MS. So low titer of MOG antibodies are usually non-specific, but titer at 1 in 100 and above are highly specific for MOGAD. And this is what's different between it and aquaporin 4. How do we differentiate NMO-SD from MOGAD? Number one, as I mentioned, there is no specific ethnic origin for MOG, while for the aquaporin 4 antibody, the NMO-SD, it's more common in non-Caucasian, especially in Eastern Asian. The sex ratio, very female predominant in NMO, almost 90% are female. In MOG antibody disease, it's almost 50-50. The brain involvement is frequent in MOG, while it's rather rare in NMO. And if present, it's usually in this typical aquaporin 4 rich region, which I mentioned, the periependymal, and so on. Optic myelitis or neuritis alone, which is recurrent, is rare in NMO-SD, but it's frequent in MOG antibodies. So recurrent optic neuritis, or what we call in the past CREON, chronic relapsing inflammatory optic neuritis, think of MOGAD. Recurrent isolated myelitis, again, think of MOGAD. And these are typical presentation. MRI feature, and this very interesting study, the main MRI feature that differentiated the two on brain were these juxtacortical lesions. You don't see juxtacortical lesion at all in NMO because most of the aquaporin 4 antigen is in the periependymal area. Another typical lesion of MOGAD is the conus medullaris lesion, and we see it frequently. So if you have a demyelinating syndrome and you have a lesion in the conus, think of MOGAD. And it's not usually seen neither in MS nor in NMO-SD. So how to differentiate MS from MOGAD? Now we looked at how to differentiate the MOGAD from NMO. How to differentiate MOGAD from MS? Number one, if you have, as I mentioned, the simultaneous bilateral or recurrent optic neuritis, the CREON syndrome, it's rarely seen in MS. It should be suggestive of MOGAD. If you have a prominent papillitis of the disc initially, a swelling of the disc with the acute optic neuritis, you don't see that in MS, you can see it in MOGAD. Of course, the LETM on spinal MRI, the extensive optic nerve lesion or the chiasmatic involvement on optic nerve, not seen in MS, but these are seen in MOGAD and in NMO-SD, so they don't differentiate the latter two. Of course, if you have a supratentorial MRI that is normal in a patient with acute optic neuritis, myelitis or brachial encephalitis, you should think more of MOGAD. And again, the absence of periventricular inferior temporal lobe and the Dawson finger, this is typical of MS, not seen in neither MOGAD nor NMO. And the very large confluent T2 brain lesion suggestive of ADAM in the brain, again, typical of MOGAD, not MS. The CSF, similar to NMO-SD, high white blood count, with a neutrophilic precytosis, absence of oligoclonal and against MS, and for MOGAD in this case. Now, a clinical feature that is very interesting that, and I learned it from clinical practice also, is the flare-up after steroid taping. You know, in MS, we give 5 days of IV steroid, the patient do well. You don't even give steroid afterward, or if you give, you taper quickly. Once you have a patient that will relapse immediately after stopping steroid, think of MOGAD. It's a steroid-dependent symptom. And especially in a patient that keeps recurring every time after you taper steroids. And again, remember that MS therapies will worsen NMO and will also worsen MOG, especially interferon and natalizumab, which have been seen or shown to worsen the disease. So at the end, between MS, NMO-SD, MOGAD, and ADAM, actually, it's really a spectrum of demyelinating disorder with a lot of overlap in between. But as we are advancing more in the science, the MRI science, the biomarker, the antibodies, the clinical experience, we are able slowly to differentiate these different demyelinating syndrome from each other. And it's extremely important to differentiate them because the therapies are completely different, and we'll be doing our patient a major disfavor, but not make a right diagnosis and then not giving the right treatment. So in conclusion, there is no single clinical manifestation that established diagnosis of NMOSD or MOGAD. Aquaporin for IgG are, remember, highly specific for NMOSD. Once they are positive, it's almost diagnostic. High MOG antibody titer above 100 are highly specific for MOGAD, but not low antibody titer. Always rely on cell-based antibody assays, ask for them for these antibodies. And finally, I went over different clinical, radiological, CSF biomarker that can help us differentiating between those three diseases. Thank you very much. Back to you, Maya.
Thank you, Professor Yamoud, for a very enriching presentation, as usual. So just allow me to take a few questions.
Sure.
So the first question, someone is asking, how can you differentiate a diagnosis of a patient with NMOSD with actually negative anti-aquaporin 4 level and neurosarcoidosis? So do neurosarcoidosis share common feature with NMOSD with negative anti-aquaporin 4?
Yeah, it's a very good question. Now, neurosarcoidosis is really one of the great mimickers in neurology, which it can mimic any disease. Now, many studies in one of the best MS center in the US have shown that around 50% of the neurosarcoidosis cases were missed as MS or NMO for almost 10 years. So this is not really an easy diagnosis to make. Let's start here. But how to differentiate? Number one, you can have LETM in neurosarcoidosis, just typical. But the periependymal lesion, which are localized where the aquaporin 4 antigen is present, are not seen in neurosarcoidosis. In neurosarcoidosis, you have a significant involvement of the posterior fossa, the brainstem, centrally, and you have a lot of meningeal enhancement because it's also a meningoencephalitis. You don't see that usually in NMO. Finally, there is a specific sign in neurosarcoidosis, which is called the trident sign. And the trident sign is the sign you see it on a cross-section, transverse section of the spine MRI, showing the inflammation that look like a trident. I have to see you a picture. And this is also very suggestive of sarcoid. The other point with sarcoidosis is trying to look for systemic involvement. And usually we look at the lungs, we look at lymph nodes, we do gallium scan. And if you are able to have any evidence of activity or involvement, we go for a biopsy. And most of the time, the ultimate diagnosis of sarcoidosis is made by tissue biopsy, not before that. So this is grossly how I would try to differentiate between these two entities. And remember that both will respond very well to B-cell depleting therapy.
Another question, how do the treatment of MS differ from the treatment of NMOSD?
Yeah, as I mentioned, the treatment of NMOSD, which I think Dr. Mira is going to talk about them now, is basically have to target either the B cell, the interleukin 6, or the complement. While the treatment of MS, beside the B cell depleting therapy, target completely different mechanism and usually are really more targeted toward the lymphocytes, which we think the B and the T lymphocyte are the main pathophysiological precursor of the demyelinating inflammatory demyelination. And the problem is that many of the medication with MS like interferon, natalizumab, and we reported even dimethyl fumarate can exacerbate severely NMO. And we even had like 2 fatalities on dimethyl fumarate, which we reported just by using dimethyl fumarate in a patient that turned out to have NMO. So the only common treatment between the two are really the B-cell depleting therapy. So the B-cell depleting therapy will hit probably both NMO, MS, probably MOGAD, but not as good as they would hit NMO, and actually for the other question, neurosarcoidosis. Now, for the older treatment of NMO, we used to use thioprin, we used to use also prednisone. We don't do that much today because we already have the B-cell depleting therapy and the new treatment now that we have targeting interleukin 6 and complement. So the treatment are completely different, except for a common ground with B-cell depleting therapy, and actually treatment of MS can worsen significantly. And also we have to be very, very careful about our diagnosis.
Since we are talking about the treatment, so Amal is asking, do we know what is the physiology or mechanism why interferon or natalizumab can increase the risk of relapse in NMOSD? So do we know why they exacerbate?
No, we don't have a clear answer to that yet, actually. It has to do probably with the interaction between the T and the B cells. Now we know that the aquaporin 4 antibody is produced by the B cells like any other antibody. And we think that some of these treatments that can suppress some of the T cells, which are really Treg cell, T regulator cell that control the B cells, you will lose this regulation of the B cell, and then the B cell will be able to proliferate and produce more antibodies. This is a theory why lymphocyte targeting treatment MS, which also target the Treg cells, might exacerbate the B cell production of the aquaporin 4 antibody.
And another probably final question, can we give anti-CD20 depleting therapies in pediatric patient diagnosed with NMOSD?
Sorry, قطشت بالأول, what did you say?
Sorry. So can we give anti-CD20 B-cell depleting therapy in pediatric patient diagnosed with NMOSD?
Yes, we can. And we've been using, as you know, my B-cell depleting therapy in pediatric cases down to 10-year-old with both MS and NMOSD. And we have actually patients where we started treatment at the age 12, and they've been on treatment now for almost 11, 12 years with B-cell depleting therapy, doing very well with very good long-term safety issues. So yes, we can use it in pediatric cases.
And another question from Dr. Tfaili, who is saying hi to you. So Dr. Tfaili is asking, what about pediatric patient diagnosed with MOGAD? How do you treat them?
Hi, Dr. Tfaili. Basically, initially we used to treat them with rituximab. More recent studies are showing that mycophenolate might be a little bit more effective actually than natalizumab. So we're tending more and more, than rituximab. So we're tending more and more now to use mycophenolate, of course, at certain doses that has to do with pediatric cases. But you can still, if it's not available, you can still use rituximab. So this will be the two options right now.
Thank you, Professor Yammout. We'll have another presentation with you by the end of this webinar. So we will move to our second speaker. So our second expert is Professor Milkos Zillox. So Professor Milkos is a consultant neurologist at Tawam Hospital in affiliation with Johnson Hopkins Medicine, Al Ain Abu Dhabi, Emirate, UAE, and he's the consultant diagnostic neuroradiologist telemedicine at Kalman Pandi Bekes Country Teaching Hospital, Hungary. He served as a neurologist at the Department of Neurology and Clinical Electrophysiology at Pandi Kalman Bekes Country in Hungary initially, and as a staff neurologist, then as a consultant neurologist. He authored a number of publications in neurology, international peer-reviewed, and in specialized medical journals. Professor Milkos will discuss the latest therapies approved for the treatment of NMOSD. Professor Milkos, it's our pleasure to have you with us tonight as a speaker. Please start your presentation.
Thank you very much, Maya, for kind introduction. I will try to share my screen.
Yes. Sure.
If you can see it.
Yes.
And I welcome everyone to this session, and thank you very much to Roche to invite me for this presentation. We're going to talk about latest treatment updates in NMOSD. And I think as just continuation of Dr. Bassem presentation, which is a continuing bringing us to the practical issue treatment of quite complex pathology. I will just repeat in general what we already know. NMOSD is lifelong debilitating autoimmune disease, which is usually targeting nerves and spinal cord, but not only exclusively. We know it's a disease which with a single relapse can lead to permanent disability or even death. And disease might be silent several years, and suddenly we might have a debilitating relapse at some stage, unpredictably. Of course, our treatment strategy is a rescue treatment in time when we have relapse, and of course, maintenance therapy to prevent debilitating relapse in the future. Unfortunately, therapy is not sometimes not doing this job, and we practically might have relapses in not achieving therapeutic goal what we have. I will skip this slide because Dr. Bassem presented this, but again, we have a same, and just not need to repeat, we have a deal with rare disease. Majority of patients female. Disease is presented with optic neuritis and longitudinal transverse myelitis, significantly influencing quality of life. Usually patient is older than patient with MS, and sometimes we might have an onset in childhood and mid-age, and disability accumulates with each subsequent relapse. Luckily, we have data from Gulf area, which was published in 2020 by Islam Shusha and group, and there was reviewing the cohort of patients, which was they collected 144 patients, and as you can see, 50% of patients was presenting with unilateral or bilateral optic neuritis. 30% of patient was patient with transverse myelitis. 65% of patients had a positive serology for clopidogrel 4, and patient was presenting with relapsing form of disease in 80%, but 20% might have a monophasic disease, as we know. And finally, disease modifying therapies was reviewed, and it seems to me we have a 45%. Our group was Gulf group was treated by rituximab, followed by azathioprine, and other treatment, steroid plus immunosuppressant, and so on. At the same time, authors was emphasizing the azathioprine failed, it had a suboptimal response in more than 40%, followed by mecafenolate in 30%, and rituximab failed or have a suboptimal response in 16%. Here you can see guidelines, which was released in the last 10 years, and different authorities, which is you see on the left side of the slide, suggesting a different level or different medication, but level of evidence quite low. It's between 3 and 4. Due to the study, majority of study has a small number of participants, and practically they're not reflecting what exactly is going in the real life. So if you see therapy breaking down to 3 lines, line 1, which is the majority of authorities suggesting azathioprine, rituximab, or rituximab alone, or in combination with other treatment. Second line, it's immunosuppressant, mecafenolate, Cellcept, and mitaxantrone, and again, cyclophosphamide. And line 3, you even can see a combination of therapies with tocilizumab, which was actually came to the market in 2003 as IL-6 antagonist. So it's interesting to see we have this quite robust suggestion how to treat the patient, but all of them has a very low evidence. This is it not the abstract painting? Is it just a blurred picture of one of the cartoon, which was published in 2022 in review article, which is was reviewing progressive treatment of neuromyelitis optica and suggesting novel insights of therapeutic possibilities. If you can see this cartoon in that way, we have several compartments. There's a CNS compartment with main players, cells, neurons, astrocytes, oligocytes, and all other players which are participating in pathophysiology. We have a brain-blood barrier and dividing the central compartment from peripheral. And on peripheral circulation, we see all immunological players of participating in NMO spectrum disorder. So if you look at the right side, lower part of the slide, you can see the therapies, suggested therapies, which is breaking down the four types. As you can see, first-line therapy, which is, we know it's plasmapheresis, glucocorticoids, rituximab, here mycophenolate, immunoglobulin, and all these therapies is practically we're using as a first-line treatment or medication as a glucocorticoid rescue therapy with plasmapheresis. All of them targeted the depletion of aquaporin 4 antibody. So second-line therapy, as we was discussing, is methotrexate immunosuppressant, which is targeting T cell lymphocytes, and practically that one, the second line was using in the past. And we have finally new biological therapies, which is targeting 3 different targets, which is one of them CD1920, B cell therapy, complement 5, targeting complement 5. And finally, we see treatment which is targeting IL-6 receptors. So number 4 therapy is stem cells transplant, and another new pathway to block interleukin 23, interleukin 17, and T helper 17 pathway, which is as well participating in aquaporin 4 depletion. So I would like to concentrate on interleukin therapy today. And if we're going to introduce satralizumab, it's we know it's humanized IL-6 receptor antagonist, which is using recycling antibody technology. And finally, for maximal sustained suppression of IL signaling. So practically, that is a mode of action of IL antagonist. We know interleukin 6 is one of the key driver of neuromuscular NMOSD, and when we are applying interleukin 6 on periphery, we're decreasing the production of aquaporin. We're decreasing C-cell mediating inflammation and improving permeability of brain-blood barrier. And second to this, we're changing with protecting astrocyte injury. We know very well the NMOSD is it humoral, has a humoral background pathophysiology. MS has a cell background pathophysiology. Satralizumab was actually introduced recently as one and only approved home treatment for NMOSD in UAE. And we discussed novel mechanism of action, which was specifically developed for NMOSD. It was proven in 2 pivotal studies, which was running as a monotherapy with placebo and combination with immunosuppression therapy. Also, the drug is very well tolerated over 2-year study. No really infection rate increased versus to placebo. And all this treatment can be done at home or in clinic and very suitable for administration at home or clinic itself. We have 2 pivotal studies, which is I want to briefly comment. It's Sakura Sky, which is has a simple design. Study was initiated in 2014. And key inclusion criteria was adolescent and adults with seropositive and seronegative aquaporin 4, 2 or more relapses in last 2 years, 1 or more relapse in 1 year, And usually patient was taking, receiving immunosuppression therapy. So it was an event-driven recruitment. So double blind period was lasting 107 weeks. And it was randomization was based 1-to-1. It altogether was randomized 83 patients. 41 was randomized in treatment arm, and 42 in placebo arm. Placebo arm patient was receiving immunosuppression therapy. After 107 weeks, when patient was staying, have recurrent relapses, there was moved to open label extension arm. And there was continuous study. Actually, study was completed in 2021. Patient characteristic you can see on this slide, and you see equal distribution of seropositive patient in two arms. Mean age was around 40. Adolescent number was quite small, 3 and 4. Gender-wise, it was predominantly females. Relapse rate in 2 years was around 1.4, 1.5. EDSS score, mean the EDSS score was around 3 and 3.8. And immune suppression, you can see therapies, you can see here, it was oral corticosteroids in majority of cases, 40%, for the 40%. Azathioprine was used in 30 and 39%. Cellcept was used in 19 and 10%, and combination of therapies was used in 7 and 2%. Study showed significant reduction in relapse risk versus placebo in treatment arm in patient who was receiving IST. And at week 48 and week 96, approximately 79% the patient has a relapse rate reduction. Study was concluded as a combination with people who combination in combination with immunosuppression therapy, and 9 out of 10 patients remained relapse-free at 2 years versus 5 out of 10 for placebo. Here you can see safety profile of sotrovimab. Interestingly, only 3 side effects was mentioned in patient with which was treated with sotrovimab, is headache, injection-related reaction, and arthralgia. So rest of side effect was not significantly different. Another study, which is Sakura Star, it was monotherapy trial, and you can see design very similar. So it was only adult reported with seropositive and seronegative NMO. And it was requirement was 1 or more attack in the last year. Randomization was 2-to-1. So there was randomizing a double number of patients to treatment arm. And placebo arm randomization was 32 versus 63. And after end of double-blind period, which was 96 weeks, the patient who required treatment or has a relapse, there was moved to open-label extension study, which was running. Here you can see patient characteristic, which is only patient with seropositive status was mentioned. 41 was 65% was in the treatment arm, 70 in placebo arm. Mean age was around 40 and 45. Gender-wise, it was most of the patient female again. Relapse rate 1.5 and 1.3. No significant difference. And EDSS score was 3.6 and 3.9. Result of study showed that approximately 74% of patients had a relapse risk reduction, and at weeks 48 and 96, it was 82% relapse-free at week 48 and 76 relapse-free at week 96. So the conclusion was the monotherapy patient who was on monotherapy, 8 out of 10 remains relapse-free at 2 years versus 4 out of 10 for placebo. Same story with safety. We have some above 5% patient in treatment arm has arthralgia, headache, rash, injection site reaction, pruritus, serious infection was mentioned in 9% of patients, insomnia. So majority of adverse reactions were mild to moderate, but no increased rate of infection. No anaphylactic reaction or death was seen. No patient discontinuation secondary to side injection-related reaction, and no specific vaccination was needed for initiation of treatment. That one, how dosing schedule as well, quite simple. The patient receiving sotrovimab 120 milligram per milliliter at week 0, week 2, and week 4. And after monthly, every 4 weeks, monthly once for treatment period. So it's suitable for administration at home, as we discussed, and it's give the freedom. Sotrovimab can be used as monotherapy or in combination with immunosuppression therapy. So it's one of the first medication which is proven to reduce relapse rate reduction, which is using sub-Q. And in regards to efficacy, it's proven in 2 pivotal trials as monotherapy and in combination with IST. Sotrovimab has a superior relapse risk reduction versus placebo, clearly. Safety, it's safe medication, well tolerated over 2 years of study. No increased rate of infection or no serious infection versus placebo, including meningococcal or opportunistic infection. No anaphylactic reaction or deaths were observed. And medication gives flexibility to have a treatment as monotherapy or in combination with IST for adults and adolescent patients. It's suitable for administration at home or in clinic. And finally, we can conclude that combination therapy with IST has a quite good relapse rate reduction profile, 9 out of 10 versus 5 out of 10. And monotherapy has a 8 out of 10 has a good response versus 4 out of 10 is placebo. When I participated in one of the webinars, which was led by Trabos, who was participating in the study. He was showing this slide, the introduction of sotrovimab changed completely the algorithm of treatment in British Columbia University. So they put as a suggested first-line therapy sotrovimab, azathioprine, mycophenolate. Second line as well, sotrovimab, rituximab, and B-cell therapies. Third line, any of other 2 lines in combination therapy, and fourth line, eculizumab, cyclosporine, cyclophosphamide, and regular therapeutic plasma exchange. So in conclusion, the latest advantages in immunology, pathology, pharmacology, and other disciplines give us chance for deeper understanding of NMOSD and open a new era of NMOSD treatment. The new biological therapy with diverse mechanisms and corrective targets started to be applied in order to treat NMOSD patients and appear as effective and promising therapeutic interventions. At the same time, the efficacy of the novel therapeutic biologicals is still limited due to the lack of large clinical data and study to confirm. Thank you very much for your attention.
Thank you, Professor Miklos, for an excellent presentation. So please allow me to take a few questions.
Sure.
So the first question, in some country, or actually in many countries in the MENA region, those new biological treatments are still unavailable, or if they are available, they are still uncovered by insurance plan because, as you know, they are super expensive. So alternatively, what do you think about the efficacy of B-cell depleting therapies like rituximab in the treatment of NMOSD and MOGAD?
You know, I was looking at this question and prepared to this talk. Actually, B-cell therapy, it's available and we're using them. And rituximab, one of the B-cell therapies. And right now we have ocrelizumab, which is as well registered for NMOSD. and the new one is coming on the way. So practically that one probably choice, whatever we can use. And other choice, IL-6, which is an old IL-6 medication, tocilizumab, was piloted in many studies. Actually, they have a study of tocilizumab versus azathioprine, which is a superiority of tocilizumab. Difference between tocilizumab and satralizumab, the affiliation of satralizumab to receptors 4 times higher than tocilizumab, and they're recycling. So practically, they're staying longer time in the blood. But people, and many experts, was using tocilizumab as one of the key medication in treatment of NMOSD.
Another question: what about the treatment of NMOSD in pregnant women?
It seems to me they're using rituximab in pregnancy. They're still using rituximab in pregnant females.
So theoretically, I think all biological monoclonal antibody, they shouldn't be crossing the placenta, but since we don't have data and clinical data about the safety of the new biological, I think we should stick to rituximab currently.
Absolutely, absolutely. That was as well. Group of British Columbia University was saying rituximab is good for pregnant, but we don't have that data for the rest of medication. But practically, that's what we have. Because rituximab quite old drug.
Yeah.
Using.
And a final question about long term of all these biological. So as we all know, so NMOSD, MOGAD, they are all chronic disease, and patients need to be maintained on all these monoclonal antibody for long period of time. So what do we know about the long term safety?
We don't know anything because we don't have a study. The study, whatever was right now, satralizumab was approved, is 2 years. So actually, there was running 4 years from 2014 to 2021, but officially, it's still with the closed recruitment in 407 weeks. And my problem with all these drugs is we don't have any data which is showing us what is happening after 5 years or 10 years or 15 years, because practically we might have one relapse, and after that we have a long time nothing, even without treatment. And you don't know what is going on. And for example, if you're talking about satralizumab, it's extremely expensive medication.
Yeah.
Extremely expensive. And we have the same problem right now. We have patients who's a non-national, has a problem with insurance, even to provide the basic medication, first line medication, as well as difficult due to insurance issue. And all of them quite expensive.
Yeah, this is very true. Thank you, Professor,
my
for being with us
very much.
tonight. We will move now to the final part of this webinar. So during this, in this final part of our webinar today, Professor Yamout and Dr. Mona Thakur will debate anti-CD20 monoclonal antibodies for the treatment of MS. So the question is, should we initiate our MS patient on B-cell depleting therapy early for a better disease control, or should we delay their initiation to avoid the risk of adverse event associated with the long-term use of B-cell depleting therapy? Let us all listen to Professor Yamout, who will support the induction therapy approach. The floor is yours, Professor Yamout.
Thank you, Maya. Let me get my slides.
Sure.
Okay. So I will try to debate today, why should we start B-cell depleting therapy?
We are still not seeing your slide, Dr. Yamout.
You're not seeing it now?
No, now we are seeing it. No,
okay.
now it's fine. Okay.
Very good. So I'm going to try to debate today in favor of using B-cell targeted therapies very early on in the course of MS. Now, as we know, MS basically is a demyelinating disorder, but the problem is that it produces a secondary axon degeneration, and axonal loss in the brain is irreversible, unlike in the peripheral nerve. And studies have shown that if you look early on, most of the axonal loss is occurring in the early first 5 years of the disease. So all of this axonal loss is occurring then, and later on you have much less axonal loss. Even more than that, if we look just at the clinical picture of the patient, just the relapses, it's just the tip of the iceberg. Because for every single relapse, there are 10 more MRI lesions. And every single MRI lesion, like I showed in this pathological slides before, has a high number of axonal degeneration within it. And even in the normal apneic white matter outside the plaques, if we look at the pathology, we can see also ongoing inflammation and axonal loss, even in normal apneic white matter. So a relapse is just the tip of the iceberg of how much inflammation and axonal loss is ongoing underneath in the brain. So the question is, if we have such a significant axonal loss early in the disease, how come the patient recover very well early on and only get disabled later? And the answer is neuroplasticity. The brain recovers by having other areas of the brain take over the function of the damaged areas. This is how the brain recovers in MS, in stroke, in traumatic brain injury, and so on. So if we look here at on the left, this is a normal person activating his right hand. And this is a functional brain MRI showing activation of the motor cortex. And on the right is an MS patient 10 years into the disease who's also normal and intact, activating his right hand. And we can see the large area of brain recruited to be able to activate the hand, which means the patient is already using his brain reserve with neuroplasticity to compensate. The problem is, if we keep getting axonal loss and inflammation early in the disease, we're going to ultimately end up exhausting our brain reserve. And this is why in 10 to 15 years, when this brain reserve is exhausted, then every single new inflammation and axonal loss is going to produce disability. So this is not only the case as far as being asymptomatic. Even this early axonal loss with all the neuroplasticity, even in spite of that, we can see that early in MS, even at the CIS stage, which means the first attack, we already have significant cognitive deficits compared to control. So even early on, with all the neuroplasticity, cognitive deficit is already setting in early in the disease. And this has also been shown clinically that patients with very high number of relapses, so very active inflammation during the first 2 years of their disease, if they get, let's say, 5 or more relapse in the first 2 years, they reach EDSS-6, which means walking on a cane, by around 7 years. While if they had only 1 relapse during the first 2 years of their disease, so very low inflammation, they reach EDSS-6 20 years later. So just having very active disease early on will affect your outcome 20 years later. This is the Queen Square cohort looking at the same issue, but with MRIs, and they looked at their patient that presented initially with high lesion load in the MRI, 10 lesion or more, and 20 years later, 45% of them were already walking on a cane. While the patient that presented with a low lesion load and therefore low axonal loss and inflammation early on, 1 to 3 lesion on MRI, 20 years later, only 18% were walking on a cane. So the conclusion of all these pathological, clinical, and radiological studies is that early inflammation is ultimately going to lead to axonal loss and ultimately to disability. So the main axiom in treating MS is really suppressing all disease activity and completely, if we can, very early on. So we don't have any relapses, a new MRI lesion, disability progression. And if we do that, we'll preserve the brain reserve and therefore avoid disability in the long run. So here comes the logic that maybe we should use then early on very high efficacy medication, like the B-cell targeted therapy, like the monoclonal antibody, like cladribine, and suppress completely the inflammation early on and therefore save the brain for the future. And actually studies have been done that showed that yes, this approach works based on all the pathophysiology that I just discussed. So this is the MS-based registry where they looked at patients that were started initially on platform therapy, interferon glutamate acetate, so moderate efficacy, versus patients that were started from the beginning on high efficacy monoclonal antibody. And they followed them after 9 years, and they showed that after 9 years, patients that were on platform therapy actually had a higher rate of conversion into SPMS. So the risk of converting to SPMS, if you look at the hazard ratio here, is decreased by 34% just by having this high efficacy medication started early on, basically suppressing all the axonal loss and the inflammation very early in the disease. This is another study comparing the Swedish population to the Danish population. Now in Denmark, they use the escalation protocol. So they start low efficacy medication, and in case there are relapses, they shift to high efficacy. So 92% of the Danish population, MS patient, start on low efficacy medication. While in Sweden, they intend to be more aggressive and they start high efficacy medication, mostly B-cell depleting therapy and mostly rituximab early on. So only 65% of the patient in Sweden go into platform therapy initially, while 35%, so more than 1/3, will start high efficacy. And if we follow the two population, we can see that the Swedish population is doing much better. 6 years later, they have less risk of disability and less risk of relapses. So again, starting high efficacy medication early on will improve the outcome. Looking at the B-cell depleting therapy, specifically Ocrevus, and Ocrevus, this is the initial trial, the Opera, where it was used as against interferon. And we know that by the end of the Opera trial, the first 2 years, the proportion of patients reaching ADSS6 was much lower on Ocrevus, ocrelizumab compared to interferon, 0.8 to 3.1%. However, in the open label extension and 6 years later, the rate of patients that were walking on a cane on interferon was 8% compared to 5% with ocrelizumab. So just by not giving a high efficacy medication in those first 2 years only, we can see 6 years later how different the outcome of disability because of all the axonal loss that occurred during these first 2 years, because we're using a moderate efficacy medication versus a high efficacy. So what is lost early on here from the brain reserve cannot be regained and will still reflect even 6 years later on the disability. The other argument for using early on high efficacy medication is the concept of PIRA. Now, PIRA or PIRA is basically progression independent of relapse activity. So initially we saw that every relapse does not recover completely and leaves residual disability. However, in the Opera study, they discovered that even patients that did not have any relapses were actually showing very slow progressive disability. So progressive disability irrespective of relapses. And then when they looked at those patients, they found out that actually 75% of the disability progression in the Opera trial was actually due to PIRA, not to relapses. So as if there is progressive phase from the beginning of relapsing remitting MS that we don't see actually very bluntly, but the disease is progressing from time zero. And the issue of PIRA from the beginning is really a very worrisome concept. When they looked at the two arms of the interferon versus ocrelizumab, ocrelizumab was shown to actually decrease the risk of PIRA. So even the PIRA, the progression independent of relapse, was significantly decreased on ocrelizumab compared to interferon. So again, using high efficacy medication or B-cell depleting therapy from the beginning is also decreasing the silent progression of PIRA compared to lower efficacy medications. So why don't we use high efficacy medication from the beginning and save the brains of our patients from the beginning? Then comes the concept of balancing efficacy versus safety. There is no doubt that the outcomes are much better if you use high efficacy from the beginning. And we've shown that in many, many studies and the pathophysiology. But the issue is the safety. So let's talk about the safety of these high efficacy medication and specifically the B-cell targeting therapy. Are the safety adequate enough to use them as a first-line therapy? This is the question. This balance that I'm talking about really reflects our old concept when our high efficacy medications were really toxic. So we had mitoxantrone, which produces a 1% risk of leukemia, cardiotoxicity. We had cyclophosphamide with the high rate of infection, hair loss, cystitis. Even natalizumab earlier on, before we use the new mitigation procedure, used to go as PML. So this is why we were always balancing efficacy versus safety. But is this true today? Now we have really new DMT, high efficacy DMT that have a much better efficacy safety balance. The B-cell depleting therapy, cladribine, using the extended interval dosing of natalizumab, and so on. So let's look at the B-cell depleting therapy. This is the original Opera trial. And if we look here, even through the extension over years, compared to the interferon, the serious infection were similar to interferon, even into the extension. All serious adverse event and infection was also similar to the interferon. Now, the other question is, if we use this B-cell depleting therapy for a very long time, do we get an increased risk of infection? So this is answered by the open label extension of ocrelizumab. If you look up to 6 years afterwards, and we're looking here at the dots, not the square. The square are the progressive MS. The dots are relapsing remitting MS, which are our early patients where we want to start the treatment early. And if we compare the blue ocrelizumab to the red interferon, we can see the rate of serious infection is similar. Even later on, if we continue with the blue dots here, we can see up to 6 years, the rate of serious infection is still very low. So the medication is safe to use for a long time. B-cell depleting therapy do produce hypogammaglobulinemia. And we know that the only antibody that's relevant for infection is the IgG antibody. And if you look at 5 to 6 years later of continuous treatment with ocrelizumab, the incidence of hypogammaglobulinemia IgG below the lower limit of normal is only around 7%. And if we look at the risk of increased infection in those patients with low IgG, we can see that the risk of serious infection increased only from 2 to 5% if the patient had a normal IgG versus a low IgG. So again, a very low rate of infection, even in patients with hypogammaglobulinemia. And I've had patients for over 10 years on B-cell depleting therapy with very low rate of infections. Malignancies, is there a risk of developing malignancy if you use these B-cell depleting therapies or other immunosuppressants for a long time? This is again the risk of breast cancer with ocrelizumab, which are the blue dots. And we can see the risk of breast cancer, which here the green dot in the Swedish general population and in the Canadian population. So not general population, these are MS, the Swedish MS population. And we can see that the risk of breast cancer with ocrelizumab, even over a long period of time, is not very dissimilar to the Swedish and Canadian rate of breast cancer. And if you look at the EM label, it reflects exactly this, that there is an increased number of malignancies, including breast cancer, have been observed in the clinical trial in patients treated with ocrelizumab compared to control groups. However, the incidence was within the background rate expected for an MS population. This new approach, now that we have high efficacy medication that can control the disease very effectively early on, and with a very good long-term safety, unlike the old immunosuppressant, things are starting to change, including the guidelines. And if you look at the 2021 ECTRIM guideline published, just presented during the last ECTRIM Congress last year, now they don't differentiate between first line and second line. They say for patients with RRMS, the choice between a wide range of available drugs, and they put all the drugs from the interferon all the way to the monoclonal antibody, from modestly to highly effective, will depend on factors including disease activity and so on. And they recommend choosing a higher efficacy disease-modifying drug early on if the patient has a high disease activity. So even the guidelines are changing toward earlier use of this high efficacy medication because of the new safety data, unlike the older ones. Thank you very much.
Thank you, Dr. Yamout, again. So actually, we have one question until now. So the question is, given that ocrelizumab is not always available in many of the MENA region country, and now with the unstable economic situation in many countries, including Lebanon, so we have to shift between ocrelizumab and rituximab. So is this allowed, the shifting between the two B-cell depleting therapies?
Yes, I think it is allowed. They have a very similar mechanism of action. There are, of course, certain differences regarding the affinity to the receptors, to the risk of infection, the half-life. There are minor differences, but I've always been able to shift between the two without any problem. So when you get to the 6 months infusion time, you can exchange one infusion by the other. There should not be any issue. And when we followed our patients, like, Maya, with the CD19 counts, there was no really difference. Both of them suppressed the CD19 count to a similar level.
We have another question. What is the washout period when we shift a patient from natalizumab to ocrelizumab?
The washout period upon shifting from natalizumab to any other medication should not exceed 4 weeks. The reason is because natalizumab works basically as a lymphocyte trapper. They trap all the lymphocytes outside the blood-brain barrier. And if you stop natalizumab within 8 to 12 weeks, there's a sudden rush of all of those lymphocytes into the brain and rebound inflammation and activity. So to avoid this rebound effect, you have to have another medication that's effective before the 8 to 12 weeks of stopping natalizumab. So stopping natalizumab and starting the B-cell depleting therapy 4 weeks later, usually the B-cell is depleted down to 0 within 4 weeks of initiating the B-cell depleting therapy. So by the time you reach 8 weeks post-stopping natalizumab, you have already controlled your inflammation and avoid rebound. And the same apply for most other treatment, cladribine, alemtuzumab, fingolimod. I always use the 4 weeks washout interval, and some MS center now all over are starting to use even shorter interval, 2 and 3 weeks. So I don't think there's a problem. The only thing to be aware of when shifting off natalizumab with this short interval of washout is to make sure that the patient does not have PML. So JC virus antibody should be done, a clear MRI should be done, and if need be, even a JC virus PCR on the CSF.
Another question, what about timing B-cell depleting therapy infusion with the COVID-19 vaccine? We know now that COVID-19 now infection is fading, but what still people are getting the vaccine?
Yeah. We published our Menactrin vaccine guidelines, I think, a few months ago. For the B-cell depleting therapies, what we recommend is, as you know, the efficacy of the vaccine is significantly decreased by the B-cell depleting therapy because you need the B cells to produce the antibodies, and you don't have B cells. Usually they are down to 0 at 6 months. So if you give the ocrelizumab infusion at 6 months, then you have 0 B cells. The efficacy of the vaccine is decreased significantly. You still have the T cells that can work. So what we've been doing is, and we know from the pharmacokinetic studies of the B-cell depleting therapy that the B-cell depletion can go beyond 6 months. And we've followed cases with CD19 count. And sometimes the B-cell do not recover till 7, 8. I have patients that have recovered at 12 months, and I give them an infusion of rituximab every 12 months. So what we've been doing during the COVID-19 pandemic for the vaccine, rather than giving the infusion at 6 months, we check the B cells. And as long as they are below 1% or below 10 cells per microliter, we keep repeating the count every month or 2. Once they reach 1% or at least 10 cells per microliter, then we give the vaccine and then the infusion. At that point in time, you have enough B cell recovery, probably naive B cells, that will probably increase the efficacy of the medication. And this has been shown actually in many, many studies, from the Italian study by Sormani to other studies from France and so, that this protocol will increase the efficacy of the vaccine without decreasing the efficacy of the medication in controlling MS. And actually, once the B cell recover, the ones that recover are the naive B cell, not the memory B cells, which are the inflammatory B cells. These recover much later. So even the initial B cell recovery is going to be safer. And this is why I think the B cells effect really go beyond 6 months, probably much more than 6 months, but this will have to be looked at later on in further study. But what we've been doing for the vaccine is doing the CD count, prolonging the infusion, and giving the vaccine.
Another question, can we start ocrelizumab for newly diagnosed patient with positive PPD test, non-active tuberculosis?
Yes. Now with the B cell depleting therapy, the effect on tuberculosis is not that significant because most of the effect is through mainly the T cells, so things like cladribine and so on. But however, as a general rule, if you want to start any drug that can suppress the immune system, and we have non-active TB, usually what we do is we give a concomitant anti-TB treatment, single medication for around 3 to 6 months, concomitant with the initiation of the treatment. And this usually should be enough to control the inactive TB infection while not putting the patient at risk. But in any case, the B cell depleting therapy have not been shown to be a risk factor for exacerbating TB in inactive patients.
And a final question, for how long do we use B-cell depleting therapy in MS patients? So when do we stop?
Yeah, well, nobody knows yet. We know that the longer we go with this treatment, the higher the incidence of hypogammaglobulinemia. But as I've shown, the incidence stays low. It's below 10%, so it's not like a huge difference.
Yeah.
And at the same time, there is not a significant increase in infection rate, even with hypogammaglobulinemia. Now, to answer the question, we had a discussion once with our rheumatology colleagues in England, because they've been using rituximab much earlier than us. And they have had patients that have been using rituximab for almost 15 years now. And in their experience, there is no increase in the risk of infection. And even in patients with hypogammaglobulinemia, they don't treat with IVIG unless there is actual infection. We've had patients, as you know, Maya, now on rituximab for almost, I think now 12 years, doing extremely well without risk of infection. So I think we can use B-cell depleting therapy for a very long time, probably 10 years or more, but how long can we keep it? We don't know. I think we'll have to wait for longer follow-up studies.
Thank you, Professor Yamout, for an amazing session.
Thank you.
We will move to Dr. Mona Thakur. So Dr. Mona will support the escalation approach and thus the delayed initiation of B-cell depleting therapies in the management of MS. Dr. Mona is a well-experienced neurologist with more than 20 years of experience to her credit in UAE and India. She had her basic MBBS and MD in medicine from Nagpur University, India, and DM at DNB in neurology from Bombay Hospital, Mumbai University, India. She has completed her specialty certificate in neurology from the Royal College of Physicians, UK, and is a fellow of the American Academy of Neurology. She has worked in government hospital, Rashid Hospital, as a senior specialist for 10 years. And since last year, she is the consultant and head of neuroscience department at Al-Zahra Hospital, which is a tertiary care hospital in Dubai. She is elected board member of the Emirati Neurology Society. Her areas of interest are multiple sclerosis, headache, stroke, epilepsy, and movement disorders. She's an active researcher and has numerous presentations in local and international conferences, and she has published numerous papers in peer-reviewed journals. You are always the most welcome, Dr. Mona. The floor is yours.
Thank you so much, Maya, and thank you for the very kind introduction. I will just start sharing my slides. I hope you can see them.
Yes. Yes.
Okay, so I've been given this very, very difficult topic, and I have to speak for escalation therapy. And after this amazing lecture with Dr. Basim Yamout, I think most of you are pretty convinced to start, but I'll try to tell you the other side of the story, and I'll try to be the devil's advocate. Okay, so nobody's contesting the point that you have to start early. Okay, it's something like a stroke and you have to do thrombolysis early. You don't say thrombolysis later. Okay, the time is brain. You have to start medication early. But do you thrombolyze every patient? Do every patient need thrombolysis? But that's the question. Okay, so we know that irreversible damage occurs in axons even in the earlier stage. But remember, the therapy is most effective during early and inflammatory phase, and it is least effective during later and neurodegenerative stage. So now we have these 15 almost, and every year we are getting more and more medications. And these medications can be divided basically into 3 types. Okay, there's a maintenance, which can be used as an escalation therapy, and then there's the immune reconstitution therapy. Now, the maintenance or escalation therapy can be divided into immunomodulatory therapy or a continuous immunosuppression. So we need to choose between these, or you can try the immune reconstitution therapy. Now, the drug in question is here, the continuous immunosuppression, and we have the B cell therapies. And of course, as Dr. Bassam said, you've got to choose between, efficacy and safety. So this is a very nice graph. You see the efficacy. Okay, the higher the efficacy, the reds are in the highest efficacy range. But they're pretty high, they're low on the efficacy. And then, And then you have the middle, they are in between the efficacy and safety. And then you have the first line, which are very safe, but very low in efficacy. So you can start this way up, or you can start up, down as well. And the B cell therapies are somewhere here, very high efficacy, and they have a good safety margin as well. But I'll be questioning a few in my later slides. So now all these FDA-approved therapies target the relapsing phase of MS, but have limited impact on the progressive phase. So if your patient has already started transitioning, these very highly effective medications are actually not going to work. And then you have, then it's unclear if the relapsing phase, there's an advantage of the early aggressive phase with respect to preventing long-term disability. It can slow down the disability, but does it really prevent the long-term disability? And then, of course, you have the infectious risk and other complications associated with the high efficacy medication. So do we need all these big guns to kill small prey? So if you've got these small preys, you can use any of the rifles, maybe a stronger rifle. But do you need to use every time a artillery cannon to kill all the animals every month or every 6 months continuously? So that's the question. And this question would be to compare the risk and the benefit. And the basic principles of MS therapies is, you have to start early, start from initially, shortly after the initial symptoms. And how do you choose? Well, I'll be going through that, which factors you will need to choose the high efficacy or the medium efficacy drugs. And if you have chosen a low efficacy drug, you need to switch very fast to see if there is any breakthrough disease, could be in the form of clinical relapses or lesions or MRI activity. And if you do see an inadequate or a subtherapeutic effect, change to something with a different mechanism of action. If your patient is on an S1P receptor, don't change to another S1P, change to something different. And of course, you have these very high efficacy medications, which are the infusion therapies, cladribine and ofatumumab, which are there. And some people think that the S1P receptors are sort of medium to high efficacy. So which ones do you actually use for these patients? Okay, so do all patients need the B cell therapy early on? Well, if your patients have these bad prognostic factors, if you are of a race which has a bad prognostic, like an African American, Black, Hispanic, or if the patient is a male, or the onset is pretty late onset, or there are very frequent relapses with very, very poor recovery, particularly motor, cerebellar, or sphincter, early cognitive dysfunction, high lesion load, especially lesions in the brainstem, cerebellum, and spinal cord, new lesions in the first few years, or early OCT changes. So you've got a retinal layer thinning early on. So these patients are not for escalation therapy. You need to start high efficacy medications early. So that's what we call as the individualized therapy strategy. So if you have the presence of poor prognostic factors, you have these high efficacy medications. And if you have any adverse effects, you can change to another one. But if you have no poor prognostic factors, you still have a chance to use the first line medications. And with a very, hawk's eye on seeing resurgence of activity and switching very early on. So how common is this mild MS, which used to be called benign, and it is no longer used because none of us now actually think MS is benign. But how common is it, and how common is this highly active MS? Well, as per studies, the highly active MS is about 4 to 15%. And these patients, there's no doubt you need to go up on the high efficacy medications. But if you have a mild MS, which could be up to 80%, 30 to 80%, and these patients, the common definition is that if they have maintained an EDSS less than 3 or 4 up to 10 to 20 years, they are still considered to be mild MS. So these patients can be spared of these very high efficacy medications, which could amount to living a life without B cells. I mean, can you imagine that you're living without your B cells? So the B cells do have a function. And is repeated B cell depletion a safe and effective long-term treatment plan? And I think somebody asked that question, how long? Because there are still no data on when to stop. So if you do start these medications, when do you actually stop? And how long do we have the data? So if you have to start early B cells, suppose the patient is in his third decade, in his 20s, and he'll be having an active MS most probably up to the age of 60. So that's around 40 years more. So are you going to give him 40 years of B cell therapy, with no B cells in his body? I mean, do we have the long-term safety data of this long? Well, we don't. Rituximab, 15, 20 years data. Ocrelizumab, from the earliest trials till now, about 8 years, and ofatumumab is only 4 years. So we still are lacking a lot of data on the long-term safety. What about the late onset MS? So now we've been seeing a lot of patients who actually present after the age of 50 or very late onset, after the age of 60. The prevalence is low, about 0.6 to 12%. And we've seen that about 25% of these actually progress to secondary progressive MS. And the progressive course and the delay in the diagnosis and higher prevalence of motor disability actually characterizes this late onset MS. And these patients have actually a great risk of comorbidities that can negatively influence the course of the disease and limit the therapeutic strategies. And what we've seen that with age, there is immune system gets aged or immunosenescence, and which might be partly responsible for the transition of the disease from the inflammatory to the neurodegenerative. And then there are prevalent comorbidities, which is like depression, anxiety, hypertension, dyslipidemia, chronic lung disease, thyroid and psoriasis are the most prevalent autoimmune diseases. And of course, tumors we have the highest risk of tumors in MS in this elderly population, predominantly head and neck, breast, and digestive system cancers. So all this has to be taken into consideration when we are going to start a very high active medications. And do they actually work in the late onset MS? When the ocrelizumab study, they actually failed to reduce, the data showed that it failed to reduce annualized relapse rate in older patients more than 40. And actually it was not only the B cells, all the other medications have also shown that they have the highest efficacy in the younger patients with more active disease. And as Dr. Yamut already said, that you have to start it early on if you need the better efficacy, because they actually work only in the inflammatory phase. The Opera 1 and Opera 2, what they said was not powered to detect the statistically significant difference in this subgroup analysis. So this has to be taken with a pinch of salt, but you can see the data here that more than 40 years of age, actually the relapse rate was not significant. But that's not only with the B cells. All the therapies actually show reduced efficacy in the elderly population. And you can see this in this slide. What about the safety and of DMDs with age? And this was a study which was done by Prosperini, and they found that there's an interaction with the depleting drugs and age, which is alentuzumab, cladribine, and ocrelizumab. And they have seen a 23% variance in the neoplastic rate. And of course, they have seen that higher neoplastic rates in these patients. So you've got to be very careful when you have these patients who have presented early on to start high efficacy medications. So what have the long-term adverse events seen with the CD20? And there have been reports of hematological risks with long-term rituximab, like late onset neutropenia or thrombocytopenia. And of course, we've seen infections and infusion and injection-related reactions, more common with rituximab than ocrelizumab. And it can be, of course, dealt with pre-medications. And with the Opera 1 and Opera 2, injection site reactions were up to 34%. Hypogammaglobulinemia is an issue with CD20s, and Dr. Yamut has already elucidated in that. So each of the drugs have shown reduced IgG levels, but there was not much correlation with the low levels and serious infections. But these are still early on data, and once your duration of the CD20 goes on increasing, this will go on increasing, and you might have increased rate of infections with the low IgG levels. The other bone in contention is the infections. So you need to do a screening for all latent infections before you start CD20. And of course, there have been reports of reactivation of tuberculosis, hepatitis, HIV, herpes zoster with CD20 therapies. And somebody did ask that question about the CD20. So you need to be really careful with this, because you're going to be reducing your CD20s for a very, very, very long time. So you need to be, these patients need to be treated and vaccinated beforehand. Of course, the other infections which have been commonly seen with rituximab and ocrelizumab is the upper respiratory tract infections. UTI is pretty common, and herpes zoster has been common as well. What about PML? Well, in the studies, we did not find any PML with ocrelizumab, but then there are 10 cases of PML in the post-marketing surveillance. 8 of them were carryover. And as Dr. Yamut already mentioned, that if you are shifting from natalizumab to CD20, you need to be very careful, do your JC virus test, and if required, do a CSF PCR as well. The other important thing is malignancies, which have sort of been like a shadow around the CD20s. Now we know immune system plays an important role in both MS and cancer. And the possible activation of immune system in MS actually has a protective effect against cancer by increasing immunosurveillance. But when there's chronic inflammation and immunosuppression, there's loss of immune protection against the cancer and activation of the immune system to become more pro-tumorigenic. And that's how it happens. So you have these CD20 cells, and they cause lysis of the CD19 and 20 and reduces inflammation. But they also increase the B regulatory and the T regulatory cells, as Dr. Yamut already mentioned, which could be a factor in increasing the side effects or relapses with NMO and anti-MOG. But these could also play a role with cancer as well. So this B reg and T reg actually increase in that can increase the cancer occurrence as well. So ocrelizumab was associated with several cases of malignancy in the trials: renal cell cancer, melanoma, and breast cancers. 4 malignancies were reported in OPERA-1 and 11 in the PPMS trials, but there was no trend towards a particular type of cancer. Another very important lesson which we learned with coronavirus and CD20 was the outcome of the COVID-19 disease. And we did see that patients who were receiving 6-monthly schedule of rituximab or ocrelizumab had an increased risk of severe COVID and needed actually hospitalization. And the duration of the exposure of the rituximab and ocrelizumab also played a role. And this was seen in the North American registry. The retrospective study in the Italian study, about 784 patients, also saw that there was an increased risk of severe COVID with patients treated with the CD20s, either ocrelizumab or rituximab. This is one of our patients, actually. So this is a lady who actually started ocrelizumab very early, after the first attack. But unfortunately, the first attack was a severe attack. So she was a rapidly evolving MS. And she received ocrelizumab about 3 years back, but unfortunately developed COVID in 2020. This is before the vaccination drive had actually started. And you can see the severe COVID which she developed, but after which she ultimately succumbed. This is another patient of mine. Actually, she was an NMO who received rituximab in 2019, 2 doses. Only 2 doses, and she developed a severe hypogammaglobulinemia which did not recover. And her CD20s were just not coming up. She had recurrent UTIs to the point that she went into sepsis. So she was on every 3-monthly IVIG. And I was actually giving her since last 2 years. But February 2021, she developed COVID and she was admitted in another hospital, came back again. The COVID-19 was still positive for 3 months and she did not become negative, but she remained in the ICU for a very long time, developed severe pneumonia and ultimately succumbed. This was a patient who was having no B cells and she was unable to produce any antibodies against the COVID. And but by the time she was admitted, the convalescent plasma was out of practice, so we couldn't give her. So maybe I thought that could have helped her. We did give her a lot of IVIG, but she did not recover. So these things can be there with CD20s and severe infections as well. And vaccination, Dr. Jamut has already alluded on that when you are on a CD20, you need to be, or you're planning to take CD20, see that you've taken all your vaccinations at least 6 weeks before, because on CD20, you will not be able to give that. And if you are going to give any other vaccines, the amount of antibodies formed, it will be very, very less. What about COVID vaccine? As he mentioned that when you give it during the CD20 therapy, they are not very effective. But once the B cells start going up more than 1, then you can give them and they can develop some antibodies, protective antibodies. So that could be a problem when you are on B cell therapy continuously. But then there's another question. Suppose you stop B cell therapy, what happens? And this was a study which was done, and what they found that upon cessation of B cells, they actually, the new ones which come are actually very immature, and they incline to express more activation markers and release more pro-inflammatory cytokines. So they are more pro-inflammatory in nature. So does that have a clinical implication? So there was a large observational study actually done with rituximab, because rituximab was given into longer intervals, and they did not find any evidence of accentuated disease reoccurrence. So there's no rebound effect which comes after stopping B cells. But then there can be always individual patients which can react differently. So we need to be careful of this as well. Another thing which was seen with the rituximab therapy was it was extremely effective in stopping the relapses, but it did not prevent secondary progression, and this was a questionable finding. So when should we not use B cell therapy? So if your patient is CIS, which is extremely rare nowadays, but if you have a CIS which does not fulfill the criteria for RRMS, you still are not allowed to give B cell. If it's a mild MS, you need to have see the risk and benefit. If it is a late onset or a very late onset MS, be very careful of starting B cell therapy. If there's a high risk of malignancy, or if the patient had malignancy, we've had patients who have breast cancer. So would you start a B cell therapy? Well, I would not. Or if there's a very strong history of family history. If the patient is quantiferon hepatitis C, B, or HIV positive, be extremely careful of starting any of these therapies. Hypogammaglobulinemia, recurrent infections, especially people who have neurogenic bladder or already have dysphagia, be very careful, because this is going to immunosuppress them very, very severely. And there is always a group of anti-vacciners who just refuse to take any vaccines. Well, B cell therapy is not for them. So there are concerns with B cell therapy, long-term efficacy, safety, especially risk of malignancy, and the reason and solution for incompleteness and suppression of the PPMS progression and efficacy in non-relapsing SPMS. So if your patient is transitioning into SPMS, B cell therapies are actually not going to help much. And additionally, concerns regarding the effect of B cell depletion and the risk of COVID-19 and efficacy of vaccines during current pandemic is still a concern. So this was another very good paper of de-risking these B cell therapies. So you should do an adequate infectious screening, vaccinations before starting CD20, family planning needs to be discussed. Infusion reaction should be treated very adequately, and measuring immunoglobulin levels and reviewing vaccination annually, counseling regarding fever management. Females should be advised to have to engage with local breast cancer screening, And of course, now there is a thing about increasing the duration between the CD20 therapies and reducing the interval dosing can be actually helpful. So what's the final answer? But the final answer is in these two studies, which are now on way. So, and they will be completed in a couple of years, about August 2025. So this is the traditional versus aggressive therapy for MS. So till now, we don't have a class 1 evidence for that. So this is going to give us the real answer. So this is determining the effectiveness of early intensive versus escalation approach for treatment of relapsing MS. And then there is the Deliver MS, which aims to directly compare these treatment strategies and their impact on clinical and radiological outcomes. So the Treat MS is to evaluate jointly and independently among patients deemed at high risk versus low risk of disability accumulation, whether an early aggressive therapy approach versus starting with a traditional first-line therapy influences the intermediate term risk of disability, and to evaluate if among patients deemed at low risk of disability who start on first-line MS therapies but experience breakthrough disease, those who switch to a higher efficacy versus new first-line have different intermediate term risk of disability. And this will be completed in 2025. And Deliver MS actually seeks to answer this question. Does early treatment with high efficacy DMT improve the prognosis of the people with MS? And this is an area of significant controversy, and no data currently exists to guide treatment choices for patients and clinicians. The study results will help us guide overall treatment philosophy, will be applicable not only to a wide range of existing therapies, but also new therapies meeting a significant unmet need in patients' decision-making and aiding the decision for medication approval by third parties. And with that, I would like to thank you.
Thank you, Dr. Muna, for an excellent debate. Actually, you provided us with very convincing data for the delayed use of B-cell therapies, but after all, the decision should be individualized. There is no right and wrong when choosing treatments in MS, but the right drug should be chosen for the right patient at the right time. And remember that always treatment should be individualized, and MS is not the same for all patients. So we have some questions, if you allow me.
Sure.
So the first question, can we stop the treatment of B-cell depleting therapy after the age of 50 if there is no disease activity for 5 years and the patient is stable?
So this is very controversial, and we still don't have the real data on this. Some people go with this, that if the patient has been stable with no disease activity for the last 5 years, there's no MRI activity, and the patient is stable, maybe 55 to 60 would be a better timeline rather than 50, because now we see patients with 50 still having relapses.
And another question, how frequently do we monitor CD20 in patient maintained on ocrelizumab or rituximab, and is it really required?
No, actually it is not required. So if patients are, they present differently. Some patients can be, CD20 can be negative for maybe 18 months as well. But some people can start having their the B cell coming back in 6 months' time. So you don't want to lose that window. So before they actually start coming up, we need to give the medication to put it back down to 0, because anytime they come back, you can always get, you're prone for more relapses.
Sure. Thank you, Dr. Muna, again for being with us tonight. And with this debate, our webinar comes to its end. Thank you for our esteemed speakers. Thank you, Roche, for sponsoring this activity. And a big thank you goes for you, our attendees, for staying with us until the end of this activity. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar, you can always visit our IVPN Neuropsychiatry library, where we post all the recordings of our events. Follow us on our social media platforms and stay tuned for more activities in September. Our next activity is scheduled in September 20 and will tackle migraine. Keep your eyes on our page, as all the details will be announced very soon. Until we meet again, have a good night and stay safe.